All right, everybody, it's 5:10, so I think it's a good time to get started. Before I begin, is everyone able to see my screen and hear my voice? Perfect. All right. So for those who don't know me, my name is John Chacon. I'm a PGY1 pharmacy resident here at Stony Brook University Hospital. Today, I'll be presenting my CE presentation on drug diversion titled Jovrier, No Provier, Monitoring Controlled Substances and Preventing Diversion in a Healthcare Setting. So just a little tidbit on the first half of the title. Jovrier, No Provier is a Russian kind of saying that was prominently used during the Cold War by President Ronald Reagan in his interactions with the president of the Soviet Union, Mikhail Gorbachev. It translates to trust but verify, and I thought it was relevant, so I included it in here. All right, so nothing to disclose. And the objectives for pharmacists today are to explain the magnitude of drug diversion in the healthcare setting, list motivating and contributory factors associated with drug diversion, apply institutional strategies to prevent, detect, and investigate theft, loss, or diversion of controlled substances, analyze critical points in the medication use process with respect to diversion management and surveillance, and identify and mitigate areas for risk for drug diversion. The pharmacy technician objectives for today are define drug diversion, list motivating and contributing factors associated with drug diversion, identify methods to detect, prevent, and respond to drug diversion, analyze ways to monitor misuse of controlled substances, and understand strategies to prevent diversion. So what exactly is a controlled substance and what is drug diversion? So just getting into the definitions, controlled substance is a medication classified by the DEA and state statutes as either a C1 through C5. And they're classified based on three factors: whether or not they have a current approved medical indication, abuse potential, as well as dependence potential when abused. For example, like C1s are drugs, substances, or chemicals with no currently accepted medical use and a high potential for abuse. These include heroin, LSD, and marijuana, as opposed to, let's say, like a C5 medication, which are drugs, substances, or chemicals defined as drugs with low potential for abuse and low risk of dependence, but having a known medical use. And what is drug diversion? Drug diversion is the transfer of a prescription drug from a lawful to an unlawful channel of distribution or use. Drug diversion can occur with any type of prescription medication. It doesn't have to be a controlled substance, but for the sake of this presentation, we're going to be focusing on controlled substances, namely opioid medications. Drug diversion can occur by individuals like family members, friends, or neighbors. It can occur through businesses like drug manufacturing companies, and it can also occur in healthcare with doctors, nurses, clinic staff, as well as pharmacy employees. And the estimated costs of controlled prescription drug diversion abuse to both the public and private medical insurers is approximately $72.5 billion a year. This includes loss in productivity, mainly due to labor participation costs, drug abuse treatment, incarceration, premature death, as well as healthcare costs for drug treatment and drug-related medical consequences, as well as criminal justice costs, primarily stemming from criminal investigations, prosecutions, incarcerations, and victim costs. So which drugs are prominently abused? The classes of drugs frequently abused include opioids, depressants, hallucinogens, stimulants, and anabolic steroids in the general population. In healthcare facilities, the most common type of drug diverted are your opioid medications. And other at-risk non-controlled substances are typically your antiretrovirals, psychotropics, and insulin. Do you guys know why like those last three medications are like commonly diverted, even though they're not considered controlled substances or don't really have an abuse potential? Yeah, exactly. So they're high cost medications. So individuals try to divert them to obtain them to not pay, like standard prices. So diversion in healthcare workers. So more than 100,000 healthcare workers are known to divert annually, and approximately one in 10 healthcare workers will abuse. And drug diversion affects people of all demographics equally. There's no specific race or no specific subset of healthcare individuals that divert less than any other individuals. Nearly 40,000 diversion incidents occur in US facilities each year. For a majority of hospitals, it's estimated that 80 to 93% of diversion is going undetected. And the diversion of opioids is seen across all levels of an organization. In regards to substance abuse rates, so nurses are estimated to abuse medications approximately 10%. 15% of pharmacists are known to abuse substances, and 8% of physicians. Um, do you know what subset of physicians you would say like are more likely to abuse medications, namely opioid medications? Yeah, so typically the most prominent subset of physicians that abuse medications include your anesthesiologists. That's because they have an easier access to opioid medications in particular. They kind of draw up the doses themselves, and then they chart what they like administered themselves. So it's more easier to divert for those subset of physicians. When researching these type of statistics, I found an interesting study. A study showed that 46% of pharmacists and 62% of pharmacy students reported using a prescription drug without an authorized prescription. And 20% of pharmacists surveyed reported that they had used a prescription drug without an authorized prescription at least 5 or more times in their lifetime. So definitely some interesting statistics. And I did want to touch upon the social issues that are occurring as well. So there has been increases in opioid related overdoses recently. 40 plus states reported an increase in opioid related mortality, especially during the COVID-19 pandemic. There was a prominent increase in opioid overdoses. In March 2020, it was 18%. And a few months later, May 2020, it was 42%. And given the nature of both the opioid epidemic as well as the COVID-19 pandemic, 54% of behavioral health organizations closed their programs, and 65% turned away, rescheduled, or canceled patients during that time. So this just shows us that it's these drug diversion statistics are bound to increase based on the social issues that are occurring simultaneously. So how about the awareness of the issue? How many institutions know that drug diversion is occurring? So there was a national survey of 150 healthcare workers from over 140 healthcare systems by Porter Research in 2017. And they found that 96% of respondents acknowledge that drug diversion is occurring in healthcare, with a majority of them, approximately 65%, stating that most diversion goes undetected. Almost 1/3 felt that their organization was at risk for fines, bad press, or lawsuits due to drug diversion. And almost 1/4 reported that their healthcare facility had no established diversion prevention program in place. That's kind of an alarming number. That's 1/4 of the reported healthcare facilities had no diversion prevention at all. And this is a chart from the same survey. Along your y-axis, you have the amount of drug diversions that occurred in the respective organization within the last year. And along your x-axis, you have the percent of respondents. And as you can see, the majority of respondents reported a minimum of 1 to 5 drug diversion events within the last year. And there was another survey that occurred by the Beatty Institute for Medication Management and KRC Research in 2019, where they surveyed 650 hospital executives and providers. And some key findings is that 26% of the executives and 29% of providers surveyed believed substance abuse disorder is less prevalent among hospital employees than the general population. But a few slides ago, we see that it's actually the opposite. The reported prevalence of drug diversion in healthcare providers is synonymous with the general population. And about 40% of providers reported that they had no formal drug diversion training, which is very alarming. This is some graphs from the same study. The orange bars are healthcare executives and the blue bars are providers. And as you can see on the left here, diversion recognized as a problem with a major caveat. 85% of healthcare executives express concern about diversion, with 50% reporting that they have observed suspicious activity in their institution. And both providers as well as healthcare executives recognize that drug diversion is a problem in the United States. Another graph from the same survey conducted by BD in 2019, they surveyed these healthcare providers and executives, and what they noted is that 80% of executives and 69% of providers reported that they had difficulty in detecting drug diversion within their respective healthcare organizations. So it's definitely a prevalent issue, and it's something that we definitely have to look into. So what is the impact of drug diversion? So before we get into this, I just want to bring up the first poll question. So true or false, the effects of drug diversion are limited to the individuals that are diverting. Exactly, yep, so it's false. As we'll see in the next few slides, it's definitely not just related to the individual that's diverting. It affects various amounts of people. So the risks to the individual diverting, since this presentation is focused solely on opioid medications, those individuals are at risk for respiratory depression or cardiac arrest based on the type of medication that they're diverting. They can have infections from unsterile drugs and needles, blood-to-blood transmission of pathogens, and they also face various professional risks as well, such as felony, criminal prosecution, and civil malpractice action, as well as actions against their professional licenses. But simultaneously, not only are they putting themselves at risk, they're putting their coworkers at risk as well. Other healthcare workers can have mechanical injury or infection by bloodborne pathogens just being exposed to these individuals that are diverting. Since we all share a responsible patient care responsibility, it puts everyone on the team liable for medical legal issues. And individuals can be victims of manipulations by the diverter. So they might try to force you to breach policy and procedure, and then that puts you at risk for having disciplinary action if you're like an innocent colleague of theirs. What about risks to just an organization in general? So there's a severe risk for healthcare institutions in regards to drug diversion. There's a loss of revenue faced from diverted drugs and follow-up care for affected patients. There can be like poor work quality or absenteeism from the diverting healthcare worker. It puts the institution and themselves at risk for civil liability. Investigations from third parties like the DEA and the FDA, as well as their respective pharmacy boards. It reduces the morale of the employees, and it also reduces the trust of patients and families within that respective area. And this is like a prominent kind of situation that had occurred at Massachusetts General Hospital. And I just wanted to expand on this to show that, you know, like these healthcare organizations are also at risk due to drug diversion. So in September 2015, Massachusetts General Hospital agreed to pay $2.3 million to resolve allegations that lax controls enabled their employees to divert controlled substances for personal use. What happened was two nurses had stolen large volumes of controlled substances, nearly 16,000 pills, mostly oxycodone, from automated dispensing machines. And subsequently, the US Drug Enforcement Agency had come and audited their controlled substances, and it revealed that the pill count discrepancies totaled over 20,000 missing or incomplete medication inventories and hundreds of missing drug records. And a similar situation had arose in Emory University Hospital in Georgia. They were fined $200,000 and their pharmacy license was placed on probation for 3 years by the Georgia Board of Pharmacy. What had happened is that two pharmacy technicians diverted more than 1 million doses of controlled substances between October 2008 and July 2013. It was reported that like the scheme that was perpetuated through coordinated illicit activity, including misappropriating credentials from a pharmacy buyer, exploiting use of electronic function in the hospital system to conceal unauthorized purchases, and bypassing the receiving and inventorying process. So this drug diversion is definitely something that can affect healthcare organizations as well. And there's a substantial risk to patients as well. Let's say an individual is diverting drugs and they're using injectables, and they have like a known bloodborne pathogen, like if they carry hepatitis C and they tamper with injectable drugs, and then they remove that drug and replace it with something like saline, and they expose the patient with contamination, it puts the patient at risk as well for infection. And a few instances occurred that are prominent. In 2008, the Mayo Clinic discovered that a cath lab nurse was stealing patients' fentanyl, using the syringe on herself, then replacing with saline for use on the patient. So those individual patients that were going through cath lab procedures were getting no sedation for their procedures. And in 2013, a traveling medical technician working in New Hampshire, Maryland, and Kansas infected 45 patients with hepatitis C due to the same diversion technique. And he was convicted and sentenced to 30 years in prison due to it. This was another article I had come across. In 2009, this individual had gone to Denver Rose Medical Center to have a routine kidney stone removal performed. And after 6 weeks after the operation, they were overcome by like debilitating symptoms like malaise and fatigue. And they went to urgent care, who eventually sent them to the emergency room. And blood tests showed that they had hepatitis C from this procedure. And it was later found out that a technician stole the patient's fentanyl-filled syringes and refilled them with saline. And these type of instances are not uncommon. This chart is from the CDC, and it highlights the US outbreaks associated with drug diversion. In the past decade, there's been over 50 cases of drug diversion related infections in patients. And it's not only limited to hepatitis, but also bacteremias as well. And this chart I just included in here as well to show you that drug diversion has been occurring for a substantial amount of time. It's not only in the past decade that has become prominent. There's been instances all the way from 1985 where there were 3 cases of Pseudomonas bacteremia associated with a pharmacy technician at a Wisconsin hospital. And 1992, there was 45 cases of HCV infection. And this excerpt kind of sums up pretty well the driving point here. Healthcare culture must change for hospital staff to accept and understand that the patient is the primary victim of diversion. So this leads us into our next polling question. Which of the following statements is accurate regarding the prevalence of drug diversion among healthcare workers? Perfect. Yep. So the answer here is D. It's all of the above. There's similar prevalence amongst healthcare workers as there is in general population. About 10 to 15% of healthcare workers will misuse drugs or alcohol at some time during their career. And then more than 50 outbreak cases have been associated with workplace drug diversion since 2011. So just getting into responsibilities and signs. So as healthcare workers, we have a legal, ethical, professional, and personal kind of responsibility to not only protect our patients, but also look out for our coworkers. So what are the common warning signs for an impaired coworker that may be diverting drugs? So certain characteristics include volunteering to witness or administering controlled substances when it might not be their patient, excessive late and early administrations, use of large dosage forms requiring significant waste, And common symptoms can include major life changes or injuries that may have occurred, frequent disappearances from the floor, periods of high and low productivity that are not consistent with the normal day-to-day of a colleague. And then if they're more like commonly working like as a float or like a night shift staff, there's less supervision, so they're more easily diverted medications in those type of shifts. Other signs and symptoms include physical signs, so rapid shift in physical appearance, like their hygiene is off, weight loss or gain, if they have tremors, unsteady gait, or if they have odor of alcohol or other drugs. And then mental symptoms include like irritability, memory loss, unusual isolation from colleagues, lack of concentration, confusion, and forgetfulness, as well as lying constantly. So some of these are kind of like abstract symptoms. Some of them are more pinpoint, but it's something that we have to remain vigilant to. So what are signs of drug diversion? So if a coworker is constantly removing controlled substances without an order, if you see that product containers are compromised, if unverified verbal orders of controlled substances are being placed constantly, and being removed from these automated dispensing cabinets, if you notice that the volumes removed from pre-mixed infusions, if there's multi-dose vial overfill, and if there's consistent late documentation of administration of certain medications, these can all pinpoint to a drug diversion picture. Other signs of drug diversion include drug dispensing machines showing excessive discrepancies and overrides, excess pulls for as needed medications versus their other healthcare workers or colleagues, patients continuing to complain about excessive pain despite an individual charting pain medication was just administered, frequent unusual efforts to help administer pain medications to patients. If you notice controlled substance tampering, as well as controlled substance waste in a syringe being replaced by saline, these are all signs of drug diversion. And tampering is considered the most serious type of drug diversion because it's most likely to result in patient harm. So we've established that drug diversion is a prevalent issue, and it's consistent throughout various organizations. How do we prevent and detect it? Here at Stony Brook, we have a diversion detection software known as RX Auditor. It's a proactive diversion monitoring software. And what it does, it provides hot user lists, and it routinely reviews and audits control system data. It uses a multi-step process to facilitate identification of potential controlled substance diversion activity, and consistent with automated dispensing cabinet data as well. Their Pixis activities are compared with other users at the same station or area, and also hospital-wide. And the individuals that are like statistical outliers are listed with the color-coded metric that helps identify their level of risk for diversion activity. And how do we prevent it? So it's important to identify where diversion occurs in the healthcare environment, identify workers at risk for drug diversion, define a comprehensive drug diversion program, engage in leadership, tap into technology, and incorporate an approach into culture and training as well. So in order to prevent it, we have to understand where exactly diversion occurs. The most common points are throughout the controlled substance life cycle. So from procurement, preparation and dispensing, prescribing and administration, and all the way to waste and removal, they're all points where drug diversion can occur in the healthcare setting. So how do individuals do this? The common risk points in terms of procurement are if you purchase an order and the packing slip is removed from records, unauthorized individuals order controlled substances on a stolen DEA form, and product container is contaminated. In terms of preparation and dispensing, removing volume from premixed infusions, preparing syringe contents are replaced with saline solution as well. We've seen that multiple times in regards to drug diversion incidents in the past. In terms of prescribing, verbal orders for controlled substances are created but not verified by the prescriber, and prescriber self-prescribes controlled substances. In terms of administration, these controlled substances are being withdrawn from the Pyxis on discharge or transferred patients. and waste is not adequately witnessed and subsequently diverted. And in terms of waste and removal, um, if the waste is removed from the unsecure waste container, or if there's an expired controlled substances are diverted from the holding area. These are all common risk points. So how do we prevent it? As healthcare workers, it's important that we recognize the risk factors for drug diversion, that we have human resources screening and assessment, not only in the onboarding process and the hiring process, but throughout the lifetime of employees, monitor risky employee behaviors, and provide diversion training to our staff. So in order to do this, it's key to create a comprehensive controlled substance diversion program. And there's a multi-interdisciplinary approach. There's core administrative elements that include legal and regulatory requirements, as well as organization oversight and accountability. There's system level controls, so human resources, providing automation and technology, monitoring and surveillance, as well as investigation and reporting of drug diversion. And there's provider level controls, so chain of custody, ensuring that once an opioid medication is dispensed or a controlled substance is dispensed, that we are aware of where it is in our institution at all times, as well as ensuring that we have adequate storage and security, internal pharmacy controls, that we monitor prescribing and administration, as well as returns, waste, and disposal. So in regards to leadership, it's important that we develop a strong interdisciplinary controlled substance drug diversion prevention team. You have to train your supervisors and workers, assess existing controls, actively monitor systems, and designate a drug diversion officer. At Stony Brook University, we have Claudia, who's our drug diversion specialist. In terms of technology, it's important that we utilize the electronic health record, automated distribution devices, and pre-packaging devices, and be cognizant of what is going on with them. We have to ensure the entire life cycle supports diversion control, all the way from procurement to waste. And just a disclaimer, something that I wanted to pinpoint is that diverters can use technology to their advantage. There's so much data that we can obtain in terms of drug diversion that it might be too excessive. We might be looking at nitty gritty, and they might be able to divert certain medications that that we might overlook. So it's important to have a holistic approach when monitoring drug diversion. So for culture and training, it's important that there's a culture of safety and that individuals are comfortable saying something when they see something. Patient safety is the most paramount thing as a healthcare provider. And us as non-diverting healthcare workers are first line defense in protecting patients. And it's important to provide education for employees to detect suspicious coworker behavior. So in terms of reporting drug diversion, we all have a duty to protect our fellow employees from harming themselves and others. We should encourage employees to seek help for dependency and addiction. Once an employee suspects diversion or impairment, it's imperative that you reach out to their immediate supervisor to protect the patient. And your personal observation is vital. It may be the only clue that an individual is diverting. And it's important that we have a comprehensive audit approach as well. So you want to evaluate all relevant data for trends, variances, and improvements, include compliance reviews, identify and assess surveillance reporting, determine frequency of reviews, audits, and responsibilities, as well as audit all systems of controls from procurement to disposal. Continuing on with audit approach, the following examples are relevant to our institution. So segregation of duties, blind count documentation reviews, constantly reviewing discrepancies, auditing nursing medication administration records, discrepancy management, having a paper-based workflow, so those orange narcotics sheets that we constantly provide when dispensing controlled substances, and resources and diversion prevention program management. So how do we target diversion risk points? So in terms of procurement, we have a separation of duties. Orders are received or dated and signed by at least 2 witnesses. Procurement orders are verified for complete and accurate documentation. Audit of controlled substances purchases against products added to inventories performed at least quarterly. and unit dose packages whenever possible. At our institution, these audit of controlled substance purchases are actually done weekly by Rick, who compares what Glenn has entered into the C2 safe with the invoices provided from Cardinal. In terms of separation of duties, automation helps propose unvalidated PARs. The pharmacy buyer reviews orders and accumulation. The pharmacy leader reviews and submits the final order. The pharmacist receives the order and compares with the initial order submission, and automation reconciles order for what is received in the vault. So at our institution, our pharmacy buyer is Megan, who reviews the order and accumulates it and proposes it to their pharmacy leaders, who are Janine and John, who review and submit the final order for controlled substances. And Glenn receives the order and compares it with the initial order submission. And then once it's reconciled, Rick reviews what Glenn has entered into the safe. In terms of storage, having biometric fingerprint scanning is used for vault access. Blind counts when removing and adding controlled substances to inventory, ensuring that cameras are within the controlled substance storage area, that personal belongings are banned from the drug storage area, and vault inventory is conducted routinely, as well as controlled substance packing is routinely inspected for evidence of tampering or alteration. At Stony Brook, our inventory is done weekly. And what I found out was really interesting, even from our wholesale supplier, from Cardinal, these workers, they can't wear clothes with pockets to ensure that diversion is prevented in their respective organization as well. In terms of dispensing, you want inventory conducted routinely for controlled substances not stored in an automated vault. Controlled substance infusion stored in a secured lockbox and no port tubing. Controlled substances are never left unattended outside of the pharmacy vault, and that there's delivery and receipt by pharmacy staff and a licensed staff member in the receiving department. And then ensuring that all discrepancies that occur on the floors are resolved within 24 hours, otherwise they're escalated. And this kind of gives a method to the madness of this orange narcotic sheets that we distribute. It kind of gives us a chain of custody and it allows us to facilitate documentation of delivery of these narcotics. In regards to safe handling of controlled substances, so I'm sure that we have all read Glenn's most recent email. We want to ensure that we're utilizing the smallest dosage form possible to reduce waste or medication error, but also to prevent drug diversion from occurring. Using pre-filled, ready-to-administer syringes reduce the need for compounding a product and for manipulation to occur after dispensing. And then we want to try using the same NDC to create consistent practices across all hospitals, areas, as well as avoid bulk dosage forms. In regards to return, wasting, and disposal, pharmacy returns are verified and documented. That's why we have those orange sheets as well as the binder in the main pharmacy. And returns are inspected for package integrity. And then witness and documentation is required for wasting of any controlled substances, and random audits of unused controlled substances occurs. Again, the chain of custody with the orange narcotic sheets. And once we waste the medication in these special containers that we have, the CXRX containers, it renders the controlled substance irretrievable or unusable. In our specific institution, our containers have this pre-filled deactivating deterrent and solidifying agent. So once the medication is wasted, it's completely unusable. So this leads us into our next polling question, which is not a best practice for detecting drug diversion. Correct. Yep. So the answer is B. Personal belongings are not allowed in the controlled substance storage area. Perfect. And then also our next polling question. So strategies for monitoring misuse of controlled substances and prevention of diversion include which of the following? So I kind of gave it away. It's D, all of the above. So you want to report all suspected incidents of diversion through the appropriate channels. You want to educate staff members about signs of drug diversion and you want to implement a comprehensive audit approach. So just getting into the key points from this presentation that I want you guys to take home is that drug diversion among healthcare workers is an issue that's prevalent, serious, and under-addressed. Drug diversion poses significant risks to the employee, colleagues, healthcare organization as a whole, and most importantly, to the patients. Having a dedicated drug diversion task force to follow up on discrepancies is vital, and health systems must implement comprehensive preventative and detective tools to reduce drug diversion in the workplace. And these are just my references for your perusal. And I just wanted to acknowledge Claudia Alfiero, our drug diversion specialist, as well as Glenn, our controlled substance pharmacist, and Amanda for their help, developing this presentation. And other than that, I'd like to thank you all for taking the time out to listen to this presentation. I hope you find it insightful. With that being said, I'll open the floor for any questions at all. All right, if there's no more questions, then I'll end the session. Again, thank you everyone for coming and attending. I hope that it was relevant to your practice. Thank you.